Inside a dying heart, ventricular fibrillation looks like a chaotic electrical storm. Instead of a strong, synchronized pump, the heart muscle is reduced to a quivering, erratic spasm that pushes zero blood to the brain. For decades, the gold standard for restarting that heart has been standard defibrillation. Paramedics place pads on the front and side of the chest, the anterolateral position, and deliver a massive jolt of electricity to reset the system. But sometimes the storm is too entrenched. If a patient remains trapped in this lethal rhythm even after 3 consecutive standard shocks, they enter a state called refractory ventricular fibrillation. Once those 3 standard shocks fail, the odds of survival plummet. A routine resuscitation suddenly turns into a strict countdown to irreversible brain death. In 2022, a clinical trial out of Canada challenged the established protocols for these failing resuscitations. Published in the New England Journal of Medicine, the DOSE-VF trial provided a new blueprint for treating cardiac arrest. The researchers didn't rely on a new experimental drug to solve the problem. Instead, they attacked it mechanically, utilizing a second defibrillator to deliver 2 rapid shocks. The trial showed that this dual shock method terminated the lethal rhythm more effectively, doubling the rate of patients who survived and walked out of the hospital with their brain function intact. With those numbers, the trial moved double sequential external defibrillation, or DESED, from a desperate fringe tactic into a proven scientific strategy. To understand why one shock fails and 2 succeed, we have to look at the heart's microscopic anatomy. Cardiac muscle cells, or myocytes, are aligned in multiple different directions along various longitudinal axes. Electricity naturally travels the path of least resistance. A single shock from a single angle will hit the cells aligned with its path, but it can sweep right past the misaligned cells. Those untouched pockets of fibrillating tissue survive the shock and immediately reignite the deadly rhythm. This diagram illustrates the physical setup of DSET. While one set of pads remains in the standard front and side position, a second set is placed on the front and back of the torso, the anterior-posterior position, creating an entirely new electrical vector. Firing along this second vector creates a crossfire of electricity. This new intersecting pathway exposes a vastly larger percentage of the heart's total mass to the current. By attacking the muscle tissue from multiple geometric axes, the dual shock strategy ensures the erratic electrical storm has nowhere left to hide. Beyond the angle of attack, there is a second physical barrier: transthoracic impedance. This is simply the human chest wall's natural, active resistance to incoming electrical current. This data table from the DOSE-VF trial reveals a striking physical anomaly. When pads are placed in that front-to-back, anterior-posterior position, the physical resistance of the chest wall drops by a characteristic 15 to 20%. Because of that lower physical resistance, we see a dramatically higher current delivery reaching the heart muscle. The amount of amps spikes, even though the defibrillator's raw energy output remains exactly the same. DSED uses its dual vector geometry to bypass the chest's physical barrier, delivering a denser, highly optimized dose of electricity directly to the heart muscle. The execution of this technique requires precision. The DOSE-VF protocol relies entirely on rapid sequential shocks, explicitly requiring the operator to hit the buttons one after the other, not simultaneously. The first shock hits the heart, instantly altering the electrical state and the physical resistance of the tissue. Fractions of a second later, the second staggered shock strikes. It hits the newly sensitized heart muscle exactly inside this artificially lowered threshold window before the cells have any time to recover. It is this precise, staggered 1-2 punch, rather than brute overlapping force, that successfully terminates the intractable rhythm. Terminating the erratic rhythm quickly directly cuts the patient's total time trapped in ventricular fibrillation. A faster rhythm termination completely halts brain starvation, explaining why DOSE-VF showed significant, measurable improvements in neurologically intact survival. Despite these results, a major controversy delays global adoption: the fear that firing 2 machines into the same patient will fry the expensive hospital defibrillators. Analyzing over 1,000 cases, investigators found exactly 0% hardware damage when operators strictly used the rapid sequential method. The perceived risk to the hardware is a myth. That 0% damage rate stands in stark contrast to the proven physical preservation of human brain tissue. Currently, guidelines force paramedics into a waiting game. They must deliver and fail 3 standard shocks before they are allowed to initiate dual shock therapy. But emerging machine learning algorithms are designed to read live ECG data and predict if a patient has refractory VF right from the start. These AI tools analyze the amplitude and frequency of the fibrillation, identifying shock-resistant patterns before a single standard shock is ever delivered. Based on this potential, new trials in Europe are already testing DSED as an initial first-line strategy, exploring what happens when we stop waiting for failure. By combining AI prediction with dual vector physics, this technique is poised to shift from a desperate last resort into a calculated first strike, stopping cardiac arrest before brain damage even begins.